So I'm going to talk a little bit about the COVID-19 response, not just to the infection, but to all the people that are receiving services from, for people that are receiving services from the Department of Health and Human Services, as well as to Michiganders as a whole. So we can go to the next slide. Thank you. So I just took this from yesterday's coronavirus website that hopefully you're all familiar with if you go to michigan.gov/coronavirus. And this just tells you about our caseloads and the death rates, which is always kind of scary to look at, and the climbing, you know, the numbers that were at one point going down, and now we see some numbers going up again. And so it raises a whole host of concerns. But I think it's really important when we look at all this data is that behind every one of these cases is a human being. Behind every one of these deaths is the toll of all the people that love the individuals that passed away and all the people that were in their lives. And so these numbers really only tell a tip of the iceberg kind of story to what's going on in our society in response to COVID-19. And unfortunately, Michigan has been hit with this virus. And so we can go to that next slide. Thank you, Tedra. Oops, sorry. Yep, thanks. So I talk about this tip of the iceberg, and you can see I tried to put in this, like if you look at the top where I say today, and really as I look at disaster behavioral health, really understanding, and you could put these in many layers. I tried to put them kind of in chronological order, meaning in order of time, but you know, I don't mean to put them in order of importance, because I think they're all important in different ways, and they all impact kind of our response, our behavioral health response to this disaster of COVID-19. And so, of course, when we look back, the most recent thing that we saw was racism exposed again, on top of a global pandemic, on top of what was happening before with the opioid crisis, on top of what we all might be dealing with in terms of our life stressors as adults or children too, on top of what might have happened in our early lives with early trauma that we may have been exposed to, on top of growing up in systems and structures where there was what we call generational trauma, where many people can look back at their own heritage and upbringing and think about the different situations that impacted them as a culture, as a race. And so when we think about our responses as people, there's a lot that is stacked up right now, and there's a lot that people are dealing with. And I would say in terms of the COVID-19 response, yes, we have to deal with the infection, and I'm going to talk about that, but we're dealing with a lot more than just that infection. It's like the tip of the iceberg on top of all these other things. We could go to the next slide. So the Substance Abuse and Mental Health Services Administration federally and the Department of Health and Human Services talks about the emotional phases of a disaster. And for people with IDD, there's all sorts of other variables, and I'll talk about that more throughout my talk. But I want you to, obviously we're thinking about this with the DD lens, but this is what is talked about as a general rule for populations. That when there's like an acute, like a sudden impact kind of disaster, there's this heroic response that happens to respond to the disaster. And then there's this, what's called community cohesion, the community coming together to try and solve the immediate problem of the flood, the earthquake, some kind of big event. And then after that, there's what we call disillusionment, where it may seem like things aren't, we're realizing, we're uncovering problems. We're uncovering that we haven't fully solved all the problems that are out there. And then there's triggers that remind us of the disaster, anniversary reactions after the year, like a year after the disaster, and then working through the grief of all that was lost with the disaster, and then the building back and the reconstruction and the trying to build back better, which is a really important point that I'm hoping that people understand. Now, I put personally, talking about this a lot, I put these question marks on the side because I think we don't know for COVID-19. It's not a sudden impact disaster. It's a long-lasting, scary situation that has a variety of different phases. And so within this particular disaster, on top of these other things that have happened in our society, there's going to be like many, many mini versions of all of this happening individually and collectively. And then, of course, for people with unique situations, and if for persons with DD or other unique situations, how those responses occur, we really are going to learn a lot through this, and we don't know all the answers. But we know that there's going to be various phases and various ways that different things will impact populations differently. We can go to the next slide. And yes, people will be able to see this PowerPoint. It'll be available as you want. We can go to the next slide, Tedra.
I am, there we go.
Okay, sorry. Great. There's always that pause. Now I'll know that there's a pause. So there was a study that was published in Lancet, which is a medical journal, on general population responses to quarantine situations. And one of the things that we know emotionally is that the duration of the quarantine can impact emotions more, especially when there's an unknown duration. Like if somebody says to you, hey, just hang out for 2 weeks and the problem will be solved. Most people, even, with their own unique individual challenges, can handle like a short-term known 2 weeks, whatever, like it's just short. I get that there's an end in sight. But what we know is that when duration is prolonged and unknown, that increases stress levels. And I think that's kind of the situation we're in. We're not in the stay home order was lifted, but we're still trying to self-isolate to keep ourselves safe from the infection. And we're doing things like these Zoom meetings. And so we don't know how long this is going to last. And we keep hearing there's a vaccine on the horizon, but we still don't know how long that's going to last. And we don't know if the vaccine's going to work or when it's going to come. And so it raises like unknowns, and unknowns are always hard. There's also the fear of being infected. And I've said to many people, if I could get the ticket that says I'm going to get COVID and I'm going to have one of those asymptomatic, mild infections that I'm not going to be sick from, then I'd say bring it on and let me get it over with. But because we don't know who's going to get really sick and who's going to even potentially die, it's really scary. And nobody wants to get it because you don't have that guarantee. And we have to keep ourselves safe, and we want to keep our loved ones safe, and it's our responsibility. So that just adds to the stress level. Then we've got the problem of, okay, now we're going to try and keep ourselves and others safe, but we've got the frustration, our Zoom's not working, I couldn't get myself logged on, like all these things that happen. And then there's the boredom of like, oh my God, another Zoom meeting. Oh my God, I got to walk around the block again. Or, oh my God, I got to stay in my house a little bit longer. And how do we deal with frustration and boredom? And then, loss of routines. I was so used to going about my routine, and my routine has completely been shifted. And then loss of social contact. And the goal of the stay home, stay safe was not to completely cut off social contact, but it was to change the way we socially connect. And that's why these Zoom meetings, even though they're hard to keep going because we're probably all a little bit tired of looking at flat screens, it's really important that we keep these going because the social connection that humans need is really important. But all of these things, this was published again in Lancet at the very beginning of COVID-19. And we're seeing all this play out of being part of the emotional stress landscape. Next slide.
I don't know why I'm having this lag.
No problem. I'm going to pull my slides up so while the lag. Yeah, so the impacts on the DD population, and then we can go to the next slide. So let's talk specifically about some of that. Okay, great. So the impacts on the DD population, what does that look like specific to individuals with intellectual and developmental disorders? You know, the rates of infection, we're starting to learn more nationally. We've seen the disparities with regard to race and ethnicity, that Blacks are have been more affected by COVID-19 than white populations proportionate to the population. And so we're learning more also about the IDD, people with IDD, and we need more data. We don't have great data nationally, but there are some early studies that are showing increased impact for people with IDD, and that there may be a different age group, you know, where older adults are more impacted in the general population. It may be that younger ages are more impacted in the DD population, and we don't yet know why. It may be for people that are more likely to be living in congregate care situations. So we need more data, and we need to look at that, but we have to understand that the IDD population may be uniquely, you know, it may be that there's underlying medical vulnerabilities, you know, or other things. We don't really know fully, and so I think we're gonna have to learn a lot more about this. Also, the emotional impacts and what's unique to individuals with IDD, because it's not just the fear of having the infection ourselves, it's the, you know, a lot of the challenges with loss being a huge issue in this population, and also worries about isolation and loneliness, where the population may already feel isolated from society because of the way society is structured, isolated in general, and the loneliness that can come with it. And then concern also where individuals might need their direct support professionals, direct care workers, and personal supports to help them. And then now you're worried not just about yourself, but you're worried about the people that are supporting you to maximize your well-being. And then what about their well-being too? And I heard some really touching situations in the beginning about, for example, a person who was hospitalized with COVID next door to their direct support professional who was also having COVID, and they were luckily able to be hospitalized in a hospital room together, which really helped both of them because they were both really trying to support each other through a really complex situation. But it just means that the impacts of COVID-19 are broader and unique to this population. So it's important to think about that. And that's why I think these webinars are so important. We can go to the next slide. Okay, so what do we know about general population data? This Kaiser Family Foundation survey that was done on the general population showed that more and more people, they did a point in time, just from the beginning of March to the end of March. I haven't seen a more recent study, but I think it's really interesting that just in that little 2-week time period, more and more people were reporting feeling negatively impacted mentally by COVID-19. We can go to the next slide. And what's important, I think, for this talk is to also understand that more people were impacted with less household income. So in other words, the lower your household income, the more people felt impacted. And I agree that we need more stats. I see some of the chat going on, and we need more data on how this impacts people in our service system. We can go to the next slide.
Dr. Pinels, do you know if there's an effort to collect the data? In the chat, Someone is saying, we would like to see stats on how many folks with IDD in group homes contracted COVID, how many died, how many direct care workers contracted, how many direct care workers died. CMHS should keep this data. And is there an effort within the state to collect that data?
You know, I think there is an effort to look at all the data as, you know, across different groupings, like we've done with, you know, as we've looked at racial and ethnic disparities in COVID-19, and there have been discussions about how to look at it from the populations of people that are served by the public behavioral health system. So that would include people with IDD. I think, you know, so yes, there's conversations about doing that. Do we have that data today? No. But I think that's something that we are interested in trying to figure out how to get. And even nationally, there's not, like I said, there's only been a couple of studies that I've seen that specifically look at those population kind of data points. So that's a big, big open question.
Great, thank you.
Yeah, and if you're looking at the chat, if there's questions while I'm talking, I'm happy to answer them. It's hard to kind of multitask and look at the chat at the same time. So
we're monitoring it for you.
Excellent. Okay, we can go to the next slide. But the next slide will just show that the same data was done looking at whether if people's health status was a problem to begin with, then the mental health impacts, yeah, that's great. The mental health impacts of COVID-19 were even stronger. And so again, we're talking about the mental health impacts for people with IDD. I would imagine, again, this was not a study of people with IDD. Just to be clear, this was a general population study, but they did show that if you had problematic health status to begin with, that your mental health stressors were higher. We can go to the next slide. And so how do we look at our response within Michigan around COVID-19? So let me just explain a little bit about the structure and why it's how it's set up as a government's response, I would say, to COVID-19. Excuse me, I just have to take a sip. So we have something called the CHEC, which is the Community Health Emergency Coordinating Center. The CHEC is kind of our command center. That is the way that any disaster that gets declared as an emergency will get this CHEC to be activated. And that's when we have like the Bureau of Emergency and Trauma Preparedness that manages it, and the Public Health Administration, and everybody joins together across different agencies to participate in the emergency response. There's a formula for how systems are supposed to do emergency response. There's a whole way that through FEMA, which is the federal organization that looks at incident command systems and gathering situational awareness and updating everybody. And so what's important is that BHDD leadership, because of the whole concept of disaster behavioral health response, we have a place at the table, and we're actually on the agenda. So literally since the beginning of March, when the CHEC was activated, every day I have been on phone calls, and other behavioral health leaders have been on phone calls to listen, to hear what everybody's reporting, and to be able to report out what we think are critical issues for behavioral health and developmental, the BHDDA administration. And that's really important to have a seat at the table. There was not always a seat at the table for BHDDA in emergencies. And now there is. It doesn't mean we get everything we want. It doesn't mean that every one of our issues is top priority, because there's so many priorities to be dealing with. But having a seat at the table is really an important part of it. And I just want you to know so that your voices can be represented. So some of the early things that became clear was the need for PPE, masks and gloves and gowns and all that out in the field. Also the need, as we've learned more about testing, the need for testing. and then the need for options for persons who have co-occurring mental illness, who might need higher level of care for their psychiatric conditions. And so all of these things started a kind of like a ball rolling of activating other responses that started to play out. And we can go to the next slide. And so what happened within BHDDA itself was that the BHDDA itself had to get organized with its own response. And that started what we call the BHCRT, the Behavioral Health COVID Response Team, which had daily meetings up until July, and they're still meeting, but actually the CHEC and this BHCRT are now going to be meeting less often unless there's an emergency need to come back to daily meetings, which if we have to, we will. But all of these things, as the rates were slowing down, and of course now the rates are going back up again, but as the rates were slowing down, they just in the last couple of weeks shifted to twice a week meetings. And regular updates were happening about what was being done, including regular meetings with all of the various stakeholders, like the DD Council stood up these webinars. There were regular meetings twice a week with the PIHPs and the CMHs. In fact, there was one just today that I'm missing to be on this webinar. I started regular meetings with all the medical directors of the CMHs. So different groups started to meet regularly, and that's really important because it maintains situational awareness. It allows what I call bi-directional feedback, so that the ground up can inform the state, and the state can try and keep people informed about what's happening. We can develop policy guidance, and hopefully you've seen on the website that there's been guidance. We just issued an update to 3 of our guiding documents that just went out, or I think it just went out yesterday if it's not going out today. And then, so we can keep each other informed. I know that there's always going to be times where people are going to feel out of the loop. I used to say, I used to feel, I've been in state government for a long time, not always in Michigan. I've only been in Michigan for about 5 years, but I've always had this sense like I only know 30% of the information. And there's people that you get very upset because you feel like you don't know all the information. I think we're doing so much better about getting more information out there. We always can do better because there's always going to be information that people are going to miss, because this is such a big challenge. And so the more you can get information out, the better, and the more people will feel informed. And information helps contain anxiety, having information. And so we've put together website information on our BHDDA website. You can go there. We have COVID page that gives our policy guidance, and updates are on there. And again, these regular meetings are a way to keep people informed. I know you had Belinda Hawks and Morgan here and others that have spoken to give you all information as well. Next slide. So the bi-directional feedback that has allowed us to think about what is the continuum of care, as I say, the COVID continuum of care, like what are the needs that people have, ranging from people that have COVID and are asymptomatic to people that are full-blown and have to be hospitalized. What do they need? And then how do they get their DD needs met as well, is really important. And so just some examples, this is not all, but some of the examples were how we've been working around with our home and community-based services group, and building in stakeholder input through conversations with all of these different entities, the ARC, MyDDI, TBD Solutions, talking to them about some of their work around crisis services, and all these other advisory groups through the DD Council has been really helpful. We've participated even at the national level with NASDs. There's some podcasts we've put forth that puts some of this information out that I think are recorded and available to you as well. But all of this helps assist in understanding how individuals experience the behavioral health service system, its quality, and the satisfaction that people have with it, as well as how we can continue to improve at the individual and at the system level. We've also tried to expand access. For example, one example that I work closely with is our MC3 initiative, which is the Child Psychiatry Collaborative, which gets child and adolescent and perinatal psychiatrists out to primary care providers and pediatricians so that they can consult with these providers regarding the behavioral health needs of children with IDD, especially those with autism, but with other types of IDD as well. And also has regional behavioral health consultants to work with families and link them to behavioral health services in their community. And we have some federal dollars that fund that, as well as state dollars that fund that initiative. They have a whole website. They've been doing a lot of work to try and educate themselves and educate the public around the needs related to COVID-19. So again, there's a top-down and a bottom-up ability to inform each other and to try and keep improving the system and helping understand that, you know, a lot is being learned as we go, that we're learning from mistakes and we're learning from successes and trying to improve as we go. Next slide. Great. So I want to just talk a little bit about what's happened with the hospitals. When I did, you know, Tedra and I spoke, just trying to give you some information, because I've spent, in the beginning, I was actually spending a lot of my time focused on the licensed psychiatric hospitals as well as the state hospitals. We did have COVID-19 in 2 of our state hospitals, CFP and Walter Reuther. The state hospitals initiated protocols right from the get-go. I think those hospitals are on their 11th version of their guidelines, again, taking lessons learned. They've built model protocols that I've actually shared with my counterparts around the country. People have been really appreciative to take the lessons learned in Michigan and use them in other states. There's active training and coordination within the state hospitals. We switched all of our forensic evaluations, and unfortunately people with IDD are sometimes caught up in the forensic system when they're charged with offenses, and people question their competence to stand trial. We do these evaluations. We did a massive revision of how we do forensic evaluations now by video. We've just started doing more in person. But so there's a whole bunch that's happened through the state hospitals in terms of developing protocols and the like. Also, in the private psychiatric world, with the licensed psychiatric hospitals, a lot has been going on. We've instituted working with listening sessions to hear what the challenges are for the private psychiatric hospital system. And one of the things we learned in the very beginning is the lack of PPE in the freestanding psychiatric hospitals, which we came upon by the listening sessions. We didn't realize that a lot of the PPE distribution was happening through the general hospitals, but the general hospitals that weren't connected to the freestanding hospitals left the freestanding hospitals finding PPE more on their own or through local health, but not knowing where they stood in the prioritization. And so we were able to get more PPE to the freestanding psychiatric hospitals so that they could better manage patients with COVID-19. Also working with them, providing technical assistance and conversation so that they could develop their own protocols and share information with each other around COVID-19 management. And now we're working with the Michigan Hospital Association to develop further trainings around management of COVID-19 and other kinds of issues that the hospitals are seeing. So there's been really a both grassroots and systemic effort to look at how people with IDD can be served within the psychiatric hospitals, as well as others without IDD. Go to the next slide.
Dr. Peinel, while we're waiting for the next slide to queue up, we have a question from the chat box. Is the team also working with the educational system?
So there have been some conversations, especially in our child and adolescent services, with the educational system. And for example, we have on the Stay Well website, there's a link to, oh my gosh, I'm going to forget the acronym. I think it's called My Care, which is an emotional support tool for youth that was developed through the school system as an example of where there's been that type of partnership.
Okay. And one more question. A participant asked about, if you have any thoughts, the reason why there has been no data collection in terms of COVID-19 within the group home settings?
Well, I guess the best way to answer that is that this is a fast-moving virus and there's a lot going on, and that to do it, what would be required to do the data match, you know, takes, there's some data crosswalking that needs to occur, and there is conversation about how to do that. I don't want to say there isn't. But so that's part of it, is getting our data sets to kind of align and figure out how do we group people and sort of then look at population-based data to see who's impacted. So I would say that it hasn't happened yet in a systemic way, but there's not, and somebody's saying this in the chat, it's the way to collect the data, the only way to really do it right now would be to do some population-based data matching, which requires looking at kind of the names of who got it, and then the names of the people who died, and then crosswalking whether those names were people that were in the service system. So it's a little bit complicated, and I'm not making excuses. I'm just saying there's some logistics. We've had a lot of different data questions that we wanted to ask, you know, like with the opioid crisis, for example, or with the suicide crisis, like how do we look at special populations within these? And each one takes its own kind of pathway in terms of how to do it. So I think it's a conversation that needs to continue to be had to figure out the best way to get that data.
Thank you.
Other things that we've been trying to look at is, again, working with our child and adolescent services, developing guidelines for ABA within the COVID-19 context and giving out, we've put out some documents around somebody saying that there's no comment field in the incident reporting mechanism about whether somebody has COVID-19. And I think that's another reason why data is complicated. Just to go back to some of the things that I'm talking about, and I think this chat will be really helpful for me to take back to our leadership team. So I really appreciate your comments, and I know Vendela is going to be joining some of these conversations and has already been advocating for some of the things that she's hearing through the DD Council. So I think this is really helpful. But we're also working along the different age span, and Dr. Alexa Travis, who runs our Older Adult Services Administration, has been working to do meal delivery, including those with older adults with disabilities as well. So I think we've got things that are happening at different age spectrums that are trying to meet some of the growing needs that we're identifying, as well as looking at federal grant opportunities to serve the population.
Before we go on, we do have one more question in the chat. Some people with IDD require their direct care staff, family members to provide services even when hospitalized. Is there a discussion on how to fund these situations for continuity of care?
So the funding conversation about what can be funded through COVID-19 relief funds is a very active conversation. And there has been, a lot of discussion about personal and family supports being available to people with unique needs, and then, how to access those funds. And I know Belinda, I wasn't going to get into all the details about funding, because I believe Belinda talked about that. But again, I think if there's information in the chats or questions in the chats, that's really helpful for us to take back to the leadership. Okay. And there is a recognition, as we've done, I guess I could just say, as we've looked at, visitation guidelines and all of that, and our freedom of movement guidelines, there's definitely a part of the guidelines is recognizing that some people, for their well-being, need supports, and that's why we came out with guiding documents, which at the time was complicated to write, about how all the behavioral health services are essential for life and safety. And then the question is, taking that as the baseline, which ones can be delivered by video and which ones can't be, as we're balancing trying to keep people safe from the virus, but also trying to keep people safe for their well-being. And that's been the balancing act, I think, in BHDDA. So there has definitely been active conversation. And we've tried to issue policy guidance to help people to recognize those balancing acts about support staff and the like. And you can see the policy guidance on the website. We can go to the next slide. Again, just understanding that we have within the IDD population and within other populations, there may be risk factors that present themselves in a greater way that we have to pay attention to, including exposure to adverse childhood events, if there's chronic medical conditions, biological factors, if anyone's using alcohol or drugs, limited social networks, and acute or chronic stressors that can impact mental well-being during a crisis like this. We can go to the next slide. And so it's important that as we think about some of our messaging, what we're trying to do is think about how to hold hope and be aware and prepared as individuals. And that's something that I think is our BH message that we've been spreading around too, is that although there's a lot that we have to do and a lot of adversity, we also want to make sure that we hold hope, because it's really important to help each other build our own resilience. Next slide. And so these are the things that come from the Center for the Study of Traumatic Stress, and messages that I've been saying in a lot of my talks, and I say it here too, is that it's, again, important for us to realize, yes, this is a crisis. Like all crisis, this will end. There may be others on the horizon. We don't know when it will end, but it will end, so we just have to hang on. The majority of people will do well, and that sometimes people who've had adversity actually are strengthened by it. And in some ways, what we've seen is people gain resilience through their own challenges, and that we can call on that. So I would say for people with IDD, there are ways that people have overcome challenges in major ways that are strength building, and that we can, and I think that bonding together and thinking together about how to call on that as a source of strength and advocacy position is really important. And then also, how do we amplify kindness and generosity? I've had a lot of these conversations lately that it's not just about being kind, it's about amplifying kindness, because as we know in traumatic situations, sometimes seeing kindness is hard. And so if we can all think about how do we individually and as a whole amplify kindness, then it can help people in adverse circumstances see it more. Next slide. And those ideas are not mine. They come from the Center for the Study of Traumatic Stress. I did this at a time I was getting ready for a talk. I put together a word cloud. I don't know if you've ever done that. You can do them online for free. And I was trying to come up with, like, what are my emotions today, and trying to think, well, they're kind of balanced between hope and worry, anxiety and stress and promise, and sort of being reflective of our own reactions, resilience. So I was trying to put out like positive words, and then, you know, sort of seeing where do I land. And I kept playing with my word cloud to say, well, no, this one, that's, the worry is too great. I actually am feeling a little bit more hopeful. And you can kind of play with your emotions and put them out there in these word clouds. It's kind of a cool thing to do. But the idea is that COVID-19 at that day, you know, I was getting ready for a talk, COVID-19 very much on my mind. And we have to be aware of our reactions and attune to them. And then next slide. And then also think about what are our strategies for self-care. And we all have strategies that we've learned to use, and some of us have found new ones in this pandemic, and those are really important. Next slide. And just some tips that I go out and through behavioral health in terms of responding to the crisis and thinking about populations and needs and individuals: eating balanced meals, exercising, taking breaks, acknowledging the challenges, not minimizing them, but then figuring out that we can all learn how to address them, connecting with each other, constructive communication. I know sometimes we get stressed and tense, and being able to quickly apologize and forgive, really important tools right now. Apology, the role of apology and forgiveness is huge in these stressful times. Developing schedules for ourselves. Humans really need schedules and structure, respecting our differences, reaching out to family and support, self-check-ins, stay updated but limiting exposure to media, forgiving ourselves for being human, really important, having moments where we can be mindful and just think about where we are today, right now, to not allow ourselves to get overwhelmed about all the problems of tomorrow and all the problems that are out there, but just being grateful for our mini moments that we can take advantage of, and then avoiding drugs and excessive alcohol as coping strategies, which turn into other problems. And so just thinking about what are my strategies, we don't have time today to go into that, but just take a moment after this talk. What are my strategies for self-care that I'm proud of, and what are some of the ones I want to build? Really important. We have been from the very beginning thought about racial and ethnic minorities and their unique needs. That has only been heightened through societal circumstances, but continues to be an important area, not just for the general population, but for individuals, for the IDD population, and others. Next slide. And so just again, thinking about holding hope and instilling it as community leaders. And we all are leaders in our own worlds, even if we're not leaders in a system, even if we're individuals with IDD, you know, we are leaders for our destiny. We are leaders for the people around us. And so that's important to think about our role, about how do we keep hope going and share, just like we want to use masks to stop the spread of the virus, we want to instill hope and help that be the hope, be what gets the, you know, that should be the, we should be infectious with our hope. Next slide. And IDD systems responses and coordination, it's hard to see all the little things that I put in these circles. I couldn't figure out how to make my fonts bigger. But really thinking about in systems, it's really important to, you know, we are not alone. There's coordination. There's individuals, state agencies, federal resources, provider networks, advocacy organizations, all that partner together to try and build a better world. We can go to the next slide. And in the world of, again, the Center for the Study of Traumatic Stress, they talk about being present, connecting, communicating, and these are all messages that we've shared, communicating effectively, trying to get equipment out there, you know, in this crisis, PPE, training people, self-care, taking care of ourselves, trying to normalize reactions, providing resources, addressing the grief that comes with all the losses we've all faced, whether it's the loss related to the death of a loved one from COVID-19 or the losses of our routine. There's a lot that goes into grief. And then understanding the growth mindset, that we really can grow from adversity, and we have to be realistic, but also look to the future. Next slide. And then thinking about customized approaches, which is why I think it's so important that the BHDDA has a seat at the table in the conversations. And I'll talk a little bit about what we're doing about specialized approaches. Next slide. So we started this Stay Well website. I hope you've looked at it. This was it started as a part of Stay Home, Stay Safe, but Stay Well. And now it's just the Stay Well because we don't have the Stay Home executive order anymore. And it really is a way to try and address the emotional needs of the population of Michigan. Go to the website, michigan.gov/staywell. Next slide. We've been able to look at how to build community growth through these understanding vulnerabilities. And I know I'm conscious of the time, but just of the presentation, and you'll get these slides, but thinking about appreciating relationships, enhancing spiritual connections, and staying socially active. And I know the IDD community has really done a tremendous job in some ways leading how we all should be working together around this. Next slide.
Dr. Pinos, we have a hand raised.
Okay.
Sarah, if you want to unmute and ask your question.
I did type a question in the chat, and I was kind of wondering, why aren't the people in like group homes and the death rates in group homes reported?
So I think what we were hearing in the other form of the chat is that because COVID-19 is new, the structure of reporting incidents in group homes doesn't have a line yet for IDD populations or people in group homes, or for COVID-19. And so that's something that we have to look at in terms of our data collection, is one answer to that.
Okay, I'm sorry.
No, thank you for that great question. Okay, we can go to the next slide. So one thing I want to tell you about is that we've had this crisis counseling grant through SAMHSA and FEMA, which is the Emergency Response Federal Agency. And through that, we've been able to add the Press 8 option. So if people call the COVID-19 hotline that was stood up when the pandemic started, you can press 8 and get what we call a Stay Well counselor to talk to. We also have a peer support line and other avenues for people to talk if they're feeling stressed. But we've also, through these grants that we've gotten, sought dollars to be able to have outreach specialists and volunteer coordinators to work with unique populations to try and learn about their needs and do sort of crisis counseling around the pandemic with those populations. And one of the groups that we're hoping to get funding for is persons with IDD that I highlighted. We've identified populations that we feel need specific targets. And if we get this funding, which we believe we will be getting, we're hoping that the DD Council will partner with us around these outreach specialists and maybe hold focus groups to be able to do some of this talk that I'm doing and other kind of crisis counseling, specifically identifying people with IDD and their unique stressors and needs. So we're really excited about that as an opportunity to help meet the needs of the population. So stay tuned for more related to that. And we can go to the next slide. I know we're almost out of time here. And again, these are just examples of what the Stay Well website looks like, where you can go from one side to the other and it gives you links and phone numbers to call if you need help. You can go to the next slide. And if you want to talk to people, again, the Press 8 option on the COVID-19 hotline, 24/7, 365 availability. Next slide. We always have the National Suicide Prevention Lifeline and even the National Suicide Prevention Deaf and Hard of Hearing hotline. And then other resources available by calling 211 or calling the National Disaster Distress Helpline. So we've tried to make many, many things. We also have chat lines and text lines available as well. Next slide. And the other thing that we're really excited about, if you go to the Michigan Stay Well website, is you can click on videos. You'll see my face doing a lot of videos about managing anxiety and stress. We also have Word documents or PDFs that you can pull down that give you guides like how to deal with the stress of COVID-19, how to deal with the stress of being tested, how to deal with a whole host of other kinds of guides. We can go to the next slide. And this is just a list, and you probably can't read the slide, but if you go to the website, you can click on any of these. And one of them I highlighted was the one that some of you may have even helped develop, like supporting individuals who are deaf, blind, and hard of hearing during COVID-19. So we've tried to put guidance documents out there. We're always looking for other documents that we can put on the website to update because this, the stress is still ongoing. And we're hoping that these guiding documents are things that we'll be able to have as resources available for the people of Michigan to use when there's, if they're looking for some ways of coping with the stress. So I would say these are some of the ways, and we can go to the next slide. I think that's the end of my talk. That we've really tried to focus on not only dealing with the realities of the virus and PPE and getting, the virus spread to be less for the population, but getting the care that's needed, whether it's psychiatric hospitalization or support within living situations, but also helping dealing with the emotions that are going on in our society related not only to the virus and the pandemic, but all the things that are happening. And those are my remarks that I wanted to share with you today. We can make these slides available to you. And I'm happy to answer. I don't know if there's time for questions or if we have a hard stop, but I'm happy to take a few questions and then we can close out the webinar.
There are time for questions. So I will go ahead and stop this presentation. And I will ask if anyone, before we get to questions, Gladys made a comment about using the word cloud, emotion cloud, for a group discussion in AFC homes. She says that would be a good activity, is using that word cloud in AFC homes for people.
I think that's a great idea. And I'm not an expert at word clouds, but what I learned from doing the word cloud is you get to rate, like you say, do I want this word to be a heavier word or a lighter word? And it kind of helps you. And then when it puts it on the screen and you look at it and you say, that word worry is giant. I didn't realize my worry was going to like take over my hope. And so you kind of play with it a little bit and it kind of helps you think about it. Because I don't know if other people have done word clouds, but I found it helpful for me personally.
That's a good suggestion. Thank you, Gladys. So we will just go ahead and open it up. Are there any questions for Dr. Pinels? I do have one. You mentioned a freedom of movement guidance. Can you talk a little bit more about that and who was the guidance issued to and what was it for?
Yeah, so when we had the stay home, stay safe order, there was a lot of confusion for people with IDD and other populations like with serious mental illness who are living, for example, in group living environments. Because the stay home, stay safe order did allow people to go out to the grocery, for example, and people could go on hikes in the park. It wasn't a complete, like you're locked in your home restriction. However, I think mostly for people who probably, I like to believe people have good intentions. So I would say probably because of the fear of spreading the virus and wanting to protect people, what ended up happening is we were hearing that some people were being prevented from going to the grocery and going to parks. And yet there was no legal authority to keep them from going to those places. And so we issued some policy guidance that said that people who are otherwise authorized to do things that don't violate the governor's order. I mean, we couldn't do things that violated the governor's order. I couldn't do things that violated the governor's order. But that people should be allowed to have that freedom of movement. And so we were trying to address, I think what happened in COVID-19 hit hard and hit fast and hit with a lot of panic. And everybody responded. Again, I like to think to the best of their ability, but we thought we needed to issue some guidance to help people understand the limits to the restrictions.
So if there was a case where those restrictions haven't been lifted now, what would someone do? If someone was living in a group home and they still have restrictions above what's legally, being mandated by the governor right now, what recourse would they have and who would they talk to?
Well, first of all, know that we have been involved with, the governor did issue an executive order, and I should have mentioned this as well. We were part of, BHDDA was very much a part of helping with that. The executive order that called for the non-discrimination based on disability in terms of rationing of care. So number one, know about that, read that order. The other thing is we did just update is the right word, the freedom of movement guideline, and I think it's now on the website. I think this is the one that I said just came out yesterday, so read that because it's now written, because there is no stay home, stay safe order. The other thing is if somebody's rights are being violated, you have options to go to protection and advocacy, you have options to go to ORR, and bring those situations to people's attention, because we wouldn't know otherwise that that's happening. And oftentimes we can address it through conversation and dealing with it. Again, I think a lot of it is misunderstanding. We also had to work, this is another thing we did to advocate for people with IDD, is we've worked with the local health departments, because the local health departments, they have and again, I think they're good people. They're coming at it from, we've got to stop the virus. And they don't understand necessarily, like you can't lock somebody in a room to stop the virus. So they might say, why can't you keep people in a room? And it's like, we can't keep people in a room. That would not be allowable. And so we've had to have conversations to understand, because we do have people who are challenged by wearing masks and who maybe even shouldn't wear masks because of medical reasons or clinical reasons, or just are uncomfortable or need special masks, or there's just a lot of issues that make the devil's in the details, and we have to have conversation to understand the unique needs of different populations and get people to the best answer. And it's really hard, I can tell you as a doctor, it's really hard. I don't want anyone to die of the virus, and I don't want anyone to suffer from rights being violated. And so we're trying to get to the right mix.
Thank you. Other questions for Dr. Pinels? Tracy, we've not checked in on our Facebook stream since we started. Are there questions or comments for Dr. Pinels on Facebook?
No, there are no questions or comments at this time.
Thank you. Well, thank you so much. This was really great information. As always, the recording and the slides, not the live stream, the recording and the slides will be available on our Facebook. No, let me stop myself. The recording and the slides will be up on the website, the MyDDI/DD Council website on Monday. In that same vein, we had a problem with the upload of the slides and the recording from June 25th. So those slides are now up there. The Morgan and Belinda from BHDDA. It was really difficult. I don't know what was wrong with that recording, but it did not want to cooperate. And so it just got up earlier this week. It took the better part of a week to get that solved. And so the slides in the recording from this June 25th waiver conversation are also up on the website. And today's recording will be up on Monday. The other thing to let you know is that there is a available until Monday. We send it out on our Facebook. We send it out via email. MyDDI send it out via email, and on their Facebook, there's a survey being circulated by Aging and Adult Services Administration. And we're hoping that we can get people with disabilities and family members of people with disabilities to take that survey. It is about, it's a survey about the impact of COVID on the aging population as well as people with developmental disabilities. And we have been trying to help get people, as Dr. Pinel said, we need data, and this is one way that we're trying to, it's a data set that we're helping to put together and collect data on. It'll take about between 10 and 15 minutes to take the survey. We did email it out. If someone would like to have it emailed to them again, please, by all means, put your email in the chat and I can send it back out to you. We send it out on Tuesday to our entire listserv, and as well as posting it. It closes on Monday, July 13th. And so we've got a few days to help get people with disabilities to get your perspective on the impact of COVID. And so that would be great if you would help us out with that. Are there any questions about that? I see one question. So for the survey, people with disabilities for all ages of people with disabilities, for people without disabilities over 60 and over. So even if you're the parent and you have a minor child with a disability, you could take the survey, or they can take the survey as well. For people with disabilities, it's of all ages.
Edra, can you also speak to the question from Pam, if somebody wants to come on to the Zoom webinars and they need sign language, would that be possible so they can participate?
That would be possible. I would need for that person to send an email to me so that I can talk with them and help to arrange a sign language interpreter. And we also do provide captioning if that, all of the webinars are captioned. So if that person is able to participate with the caption services, that's also available. But yes, Pam, they can just send me an email or you can connect me with them and we can help get them on to the webinars. We had one request for a topic for a future topic, and that was COVID-19 testing for people with IDD. I will be working with that person to get more specifics on what they are looking for, and we would gladly set up. I think that's a really important topic for our population, and so we'll be working on setting up a webinar on testing. Are there other topics that people would like to see us bring forth information about? You can unmute yourselves and talk, or you can just type it in the chat. Sarah, you got something?
Type what in the chat?
If you had a topic of a webinar that you want us to put together for future topics. Well, we will see you back here. If there are no further questions or comments, we'll see you back next week at 11 a.m. We'll get the information out as soon as possible. Next week's webinar will be on voting in the age of COVID-19. So we hope that you will join us.
Tedra, before we sign off, I just want to thank Dr. Pinos for all of that information and your time. And I know you ducked out on another meeting to be with us. We really appreciate it.
Yes.
And we'll keep talking.
Yes, I'm very excited and happy to be here. And thank you all so much for listening and for all your hard work and partnership and on everything.
Okay.
Thank you. There's a lot of thank yous coming your way, Dr. Pinos.
Be safe, everyone.
All right. Bye-bye.
Sarah, yes, Sarah.
I just wanted to let everybody know that me and MPAS are going to be co-hosting some webinars on voting. It's part of the Safe Go Voter project, and I guess we're pushing it back to the 21st, the 28th, and the 30th.
Sarah, I think that we're probably going to ask you to be part of the webinar next week. So I'm glad that you're prepared to let us know what we need to know.
Yes, I am going to be a part of this, of the webinar. I don't know if, am I doing all 3 webinars?
I'm not sure.
So you're talking about the 3 webinars with Noah. We're not sure how many. We're not sure how many of those you'll do. But what Tedra's asking is if you'll be part of ours next week as well.
Yes, yes,
okay?
I will.
Okay, phenomenal.
Perfect. Thank you, Sarah.
Yes, but I wanted to announce that so that people know that we are having the webinars on voting for people with disabilities.
Right. You said July 21st, 28th, and
30th.
And
I guess
30th.
They're pushing it back because originally they were going to do it the 14th, but because it's so soon, I guess they decided to push it back.
Okay, thank you.
To the 21st. So the first one's going to happen on the 21st. And it's going to happen at 1 p.m. All of them are going to happen at 1 p.m. on the 21st, 28th, and 30th. Right before the primary election.
A quick correction in the chat. Both Tedra and I were trying to send her email out at the same time. It is Jackson T7 at michigan.gov. Jackson T7 at michigan.gov.
Thank you, Mary. And thank you for your assistance today, Mary.
No problem.
All righty. Well, that concludes our webinar for this week. We will talk to everyone next Thursday at 11. Bye.
Okay, bye. Thank you.